Hello, everyone. Thank you for taking the time to participate in this learning experience. My name is Weston Vick. I'm a physical therapist and orthopedic certified specialist. I currently work for Kootenai Health and practice in an outpatient setting. Throughout my career, I've been passionate about the assessment, treatment, and management of pain. This led me to participate in Panhandle Health's prescription opioid solutions team. Today, I'm here to talk to you about non-pharmacological and non-surgical pain management strategies. We will discuss a variety of interventions and disciplines involved in managing pain and preventing opioid use. Physical therapy will be a primary focus of this talk, as this is my field of expertise and my field of practice. Our objectives today include the following. 1. Outline the recent available data on opioid use in the United States and Idaho. 2. Review Centers for Disease Control and Prevention, or CDC, recommendations for non-pharmacological and non-surgical pain management. 3. Explore current evidence for physical therapy in prevention of opioid use. And lastly, 4. Outline actionable strategies to improve North Idaho population's utilization of non-pharmacological and non-surgical pain management. There is a high prevalence of chronic pain in the United States. In the May 2016 issue of Military Medicine, an article titled Relieving Pain in America, a Blueprint for Transforming Prevention, Care, Education, and Research, estimated that, quote, chronic pain affects about 100 million American adults, more than the total affected by heart disease, cancer, and diabetes combined. Pain also costs the nation up to $635 billion each year in medical treatment and lost productivity, end quote. I want to outline national opioid use with data from the United States Opioid Prescribing Rate Maps website for the CDC. The page states that the total number and rate of opioid prescriptions reached their peak in 2012 before starting a steady decline. On this page, the CDC states, quote, however, in 2018, prescribing rates continue to remain very high in certain areas across the country. In 11% of U.S. counties, enough opioid prescriptions were dispensed for every person to have one. While the overall opioid prescribing rate in 2018 was 51.4 prescriptions per 100 people, some counties had rates that were 6 times higher than that, end quote. As of October 2020, national prescription rates for the United States are not currently available for 2019 or 2020. Now, we will turn our attention to Northern Idaho. Panhandle Health District was able to provide the following statistics for the Northern Idaho counties. We have experienced a rise in both the rate of opioid prescriptions and the drug-related deaths in the majority of the 5 northern counties of Idaho from 2018 to 2019. Last year, nearly enough opioid prescriptions were dispensed for 9 out of 10 North Idahoans to receive one. Lastly, the rate of opioid overdose visits per 10,000 emergency department visits has nearly doubled from 2019 to 2020. Despite increased awareness of risks associated with opioid use and updated national practice guidelines, the average opioid prescription rates in Northern Idaho have risen over the last year, reinforcing the need to supply the community with effective and safe alternative strategies to manage their pain. We will now review recommendations from the CDC guidelines for prescribing opioids for chronic pain, United States 2016, prepared by Dr. Deborah Dowell et al. In the CDC Morbidity and Mortality Weekly Report. The first recommendation includes the following statement. Quote, non-pharmacologic therapy and non-opioid pharmacologic therapy are preferred for chronic pain. Clinicians should consider opioid therapy only if expected benefits for both pain and function are anticipated to outweigh risks to the patient. If opioids are used, they should be combined with non-pharmacologic therapy and non-opioid pharmacologic therapy as appropriate. End quote. The section following this recommendation goes on to include the following 2 statements. Quote, the contextual evidence review found that many non-pharmacologic therapies, including physical therapy, weight loss for knee osteoarthritis, Psychological therapies such as CBT and certain interventional procedures can ameliorate chronic pain. End quote. And lastly, quote, non-pharmacologic approaches such as exercise and CBT should be used to reduce pain and improve function in patients with chronic pain. End quote. In addition to this recommendation, Gallup poll results from 2017 suggest that the public is interested in methods of managing their pain other than prescription medications. The information below is drawn from the Gallup-Palmer College of Chiropractic Annual Report, Americans' Views of Prescription Pain Medication and Chiropractic Care. The poll surveyed 6,200 Americans. Selected findings from this survey include the following. Nearly 8 out of 10 adults in the United States surveyed stated, quote, I prefer to try other ways to address physical pain before I take medication prescribed by a doctor, end quote. When asked the perceived effectiveness of different neck or back pain treatments, 41% ranked physical therapy as very effective, 29% ranked chiropractic care as very effective, 22% ranked prescription pain medication as very effective, 15% ranked back surgery as very effective, and 9% ranked self-care as very effective. When asked to rank the perceived safety of different neck and back pain treatments, 68% ranked physical therapy as very safe, 33% ranked chiropractic care as very safe, 23% ranked over-the-counter medications as very safe, 12% ranked prescription pain medication as very safe, and 6% ranked back surgery as very safe. There's an apparent patient preference for non-pharmacological treatments and national guidelines supporting utilization of these services to manage pain. There also appears to be a perception that prescription medications are not as safe or effective as non-pharmacological treatments for neck and back pain. Now, we turn our attention to literature examining the opioid prescribing practices in relation to physical therapy and other non-pharmacologic interventions. We will now discuss the findings of a study titled Stagnant Physical Therapy Referral Rates Alongside Rising Opioid Prescription Rates in Patients with Low Back Pain in the United States, 1997 to 2010, by Patricia Zhang, MD, and Ming-Chi Cao, MD, PhD, and colleagues, published in the journal Spine in May 2017. They examined the proportion of primary care physician visits for lower back pain associated with either physical therapy referrals or opioid prescriptions from 1997 utilizing national survey data. Results revealed physical therapy referrals remained stable around 10% as opioid prescription rates steadily increased, reaching near 45% by 2010. And, quote, furthermore, visits not associated with PT referrals were more likely to be associated with opioid prescriptions, end quote. We will now look at the study titled Management of Patients with a Musculoskeletal Pain Condition that is Likely Chronic, Results from a National Cross-Sectional Survey by Debbie Feldman, PT, PhD, and colleagues, published in November 2019 in the journal Spine. Data from a United States cross-sectional survey was used to explore clinical management of new cases of musculoskeletal pain that was likely chronic. Just under 12,000 visits were assessed, spanning a period of 9 years. Findings revealed the following specific proportions of prescriptions. 21.5% were prescribed opioids, 11.7% were prescribed exercise counseling, 10% were prescribed physical therapy, 0.4% were prescribed mental health counseling, and 0.14% were prescribed psychotherapy. Our final study is titled Opioid Use and Pain Control After Total Hip and Knee Arthroplasty in the U.S., 2014 to 2017, by Rahul Shah, BS, and colleagues, published on July 30th, 2020 in the Journal of the American Medical Association. They examined if patients following total hip arthroplasty or total knee arthroplasty received opioid prescriptions, the morphine milligram equivalent for those receiving prescriptions, and the level of pain at discharge and 2 months post-discharge. Results found that from 2014 to 2017, the portion of patients who received an opioid prescription within 60 days of discharge increased by 8.4% after total knee arthroplasty and by 7.7% after total hip arthroplasty. There was a reduction in the morphine milligram equivalent dose from 2015 to 2017, but, quote, there was no clinically meaningful improvement in postoperative pain level at discharge or even up to 2 months post-surgery, end quote. These recent findings suggest that both opioid prescribing practices and referral for alternatives may not reflect current recommendations. We need to increase society's awareness of non-pharmacological and non-surgical alternatives for pain management that are both effective and evidence-based, that lack the side effects, risk of addictions, and adverse effects associated with opioid medications. In pursuit of that, we will briefly highlight recent research suggesting that participation in physical therapy is associated with reduced likelihood of opioid use. We will highlight when the evidence intersects with other disciplines. This is a growing body of evidence, and we will touch on a small portion. The next 2 articles to be discussed use odds ratios to illustrate their findings. Magdalena Susmilas, MSc, in her 2010 paper titled Explaining Odds Ratios, reminds us that, quote, an odds ratio represents the odds an outcome will occur given a particular exposure, compared to the odds of the outcome occurring in the absence of that exposure, end quote. When the odds ratio is less than 1, exposure is linked to reduced odds of an outcome. In this case, the exposures are to physical therapy and the outcome was the use of opioids. We now turn to the article titled Physical Therapy and Opioid Use for Musculoskeletal Pain Management, Competitors or Companions? By Stephen George, PT, PhD, et al., published in 2020 in the journal Pain Reports. They abstracted adjusted data reported from recent studies that have examined early exposure to physical therapy with subsequent opioid prescriptions. The authors used reported odds ratios and 95% confidence intervals for these estimates. The odds ratios from these studies were consistently below 1 for lower back pain, neck pain, shoulder pain, knee pain, and persistent musculoskeletal pain. Quote, there is considerable convergence that early exposure to physical therapy reduces the odds of future opioid prescriptions, end quote. The majority of the studies were of observational design involving secondary analyses of claims or registry data. Lastly, we examined the results from the article titled Observational Retrospective Study of the Association of Initial Healthcare Provider for New Onset Low Back Pain with Early and Long-Term Opioid Use by Louis Kazis, SCD, and colleagues, published in the British Medical Journal in 2019. They examined the association of initial healthcare provider for new onset low back pain with early and long-term opioid use, reviewing just over 200,000 cases. Analysis found that adjusted odds ratios for initial visits to physical therapists was 0.15 and for chiropractors was 0.10 for early and long-term use of opioids when compared to those who saw a primary care physician. This analysis showed substantially decreased long and short-term opioid use associated with initial visits to physical therapists or chiropractors for new onset of lower back pain. Physical therapists are in a unique position to address acute pain while working to prevent progression to persistent or chronic pain, as well as providing comprehensive care to address patients' needs pre- and post-surgery, manage chronic or persistent pain, or to improve impaired mobility. Physical therapists use many interventions to treat patients, most commonly exercise. Physical therapists work with other healthcare members. This includes physicians and specialists in exercise, behavioral health, and nutrition. Physical therapists determine what care is within their scope and ability to provide, making sure to refer to other providers when indicated. Next, we will review the most common interventions used by physical therapists. None of these forms of treatment are unique to physical therapy and are utilized by a variety of providers. Patient education about treatment options and imaging. Physical therapists can provide education to patients about their diagnoses and treatment options, including prognosis as well as relative risks and benefits of available treatments to empower them to make a more informed decision about their care. Appropriate use of healthcare services includes using accepted criteria prior to ordering advanced imaging. Studies have shown adverse effects of imaging findings and early imaging for patients experiencing musculoskeletal pain, most significantly, lower back pain. PTs, through careful assessment and examination, can aid in screening to avoid unnecessary and possibly harmful imaging. If patients have received diagnostic imaging, physical therapists can educate patients with clear language about the results, outlining what may be asymptomatic findings indicating normal age-related changes versus significant pathology requiring further assessment or invasive treatments, stressing the importance of correlation of findings with clinical signs and symptoms, ideally reducing unwarranted fear, stigma, and self-limiting behavior. Therapeutic neuroscience education. This involves expressing to individuals why they hurt with explanations based in modern pain science, educating patients that pain is a product of the nervous system designed to protect tissues from harm that is determined by multiple processes and inputs. Paul Mintkin, DPT, and colleagues wrote in a 2017 article, Physical Therapists' Role in Solving the Opioid Epidemic, published in the Journal of Orthopedic and Sports Physical Therapy. Quote, "We need to educate our patients that the biology of pain is never straightforward, and that pain does not provide a window into the state of the tissues, and is frequently modulated by psychosocial and somatic factors. As pain becomes persistent, the relationship between the tissues and pain is less predictable, and pain becomes an output based on the brain's perception of tissue danger." End quote. A 2016 article titled "The Efficacy of Pain Neuroscience Education on Musculoskeletal Pain, a Systematic Review of the Literature" by Adrian Lowe, PT, PhD, published in the Journal of Physiotherapy Theory and Practice, found that education about pain biology may reduce pain, improve patient knowledge of pain, improve function, and lower disability, reduce psychosocial factors, enhance movement, and minimize healthcare utilization. Exercise. A significant body of literature shows positive effect of regular exercise on anxiety, depression, sleep, and chronic disease management. Regular participation in exercise and physical activity can lead to positive lifestyle changes. Mindfulness and stress management. Physical therapists utilize a variety of tools to help patients manage stress, including mindfulness, graded exposure, visualization exercises, breathing techniques, and relaxation strategies. Interventions including mindfulness have been shown to have a positive effect on quality of life, depression, as well as a small effect on decreasing pain. Physical therapists also utilize screening tools when appropriate to determine if referral to mental health services would aid in the management of pain or other psychosocial factors. Sleep. There is a growing body of literature illustrating the bidirectional role of sleep and pain, as well as the role of sleep on development and management of many chronic diseases. Physical therapists can screen for sleep disorders while working to improve quality via sleep hygiene education. Nutrition. Physical therapists can educate patients on the positive role of nutrition in their overall wellness, chronic disease management, and pain. They can provide general information regarding nutrition and facilitate referral to nutritionists and dietitians when the required education and advice lies outside the physical therapist's level of training. Manual therapy. Manual therapy, in combination with exercise, has been shown to be effective in the management of many musculoskeletal sources of pain. Manual therapy can be used to facilitate improved tolerance for participation in exercise. Finally, I'd like to conclude my talk with strategies to improve the utilization of non-pharmacological and non-surgical pain management strategies. Please consider referral for non-pharmacological and non-surgical services when appropriate for the population you serve, including but not limited to exercise counseling, mental health counseling, including cognitive behavioral therapy, and physical therapy. Please consider the variety of treatments and psychosocial domains that can be addressed to manage pain, including but not limited to mental health, physical activity, nutrition, sleep health, and mobility. Please consider employing a multidisciplinary approach when able to provide comprehensive treatment to not only manage pain, but to identify and address the cause of pain. Thank you for your time and attention.
Hello, my name is Scott Magnuson, and I am a board-certified interventional pain management specialist with 25 years of experience in chronic pain management. Today we are going to address prescribing opioids for chronic, non-terminal pain. I have several goals for this educational activity today. By the end of this presentation, I hope you will have a better understanding of which patients may be appropriate candidates for initiating chronic opioid therapy and which patients may need a different approach. Once the decision is made to initiate chronic opioid therapy, it is important to know how to start it and how to monitor it to help keep our patients safe. Just like any other treatments we offer, we have to have an exit strategy if ongoing assessment shows that opioid therapy is not meeting the goals we have set. Finally, we should recognize when someone has an opioid use disorder and is in need of a referral to a practitioner who treats opioid use disorder. When we talk about chronic pain, it is helpful that we are using taxonomy that is consistent. Generally, most of us refer to chronic pain as pain that lasts longer than 3 months. Alternatively, chronic pain is also described as pain that lasts longer than the normal expected healing time. Therefore, it is possible that pain could be labeled as chronic even if it has been less than 3 months after the onset, if the normal healing time is less than 3 months. Data from the CDC indicates that the number of opioid-related deaths declined 4% from 2017 to 2018, a positive move. However, before we congratulate ourselves too quickly, the number of drug overdose deaths in 2018 was still 4 times higher than it was in 1999. The underlying truth to all this is that most of the drug overdose deaths, nearly 70% in fact, involved an opioid. From 1999 to 2018, nearly 450,000 people died from a drug overdose involving an opioid, including a prescription opioid. This can be described in 3 distinct waves. There was an increase in opioid overdose deaths beginning in the late 1990s, which correlated with a rise in opioid prescribing for chronic non-terminal pain. This was then followed by a rise in opioid deaths beginning in 2010, corresponding to a rapid increase in overdose deaths related to heroin. Finally, a third wave began in 2013 when we started to see a rapid rise in overdose deaths associated with synthetic opioids, largely illicitly manufactured fentanyl. Illicitly manufactured fentanyl is often found in combination with heroin, counterfeit pills, and cocaine. Fentanyl is 50 to 100 times more potent than morphine, and when combined with these other substances, especially in unknown doses, can be especially dangerous. It is important to remember that opioids are not first-line treatments for chronic non-terminal pain. Weston Vick, in the previous video, gave an excellent outline of non-pharmacologic, non-interventional treatments for chronic pain. When indicated, non-opioid medications can be very helpful in even severe pain. Maximizing acetaminophen and NSAIDs is a good starting point for most types of chronic non-terminal pain. Gabapentin and pregabalin are commonly used when there is a neuropathic component to the pain, which is common in most pain patients. Topical agents, both prescription and over-the-counter, can be helpful for localized somatic and neuropathic pain. TCAs and SNRIs help with pain modulation and can be helpful in pain-related sleep disturbances. Interventional treatments are often important in helping to control severe pain without the use of opioids. Injections can be used for both diagnostic and therapeutic purposes. This can include spinal injections, joint injections, and peripheral nerve blocks. Implantable pain therapies for more refractory pain states are very effective for many types of severe pain, allowing the patient to minimize opioid use or even avoid it altogether. Botox therapy for migraines has been shown to decrease the severity and the number of migraines in people with severe refractory migraine headaches for more than 15 days per month. There are times when more conservative therapies are failing a patient, and consideration of opioid therapy for chronic non-terminal pain is appropriate. But when? We know that opioids can be powerful pain relievers and helpful in the short term for acute self-limited pain. But when is chronic use justified? There is a paucity of evidence that long-term chronic opioid therapy is beneficial, and there are very real risks associated with chronic use of opioids, some of which are serious and life-threatening. Making the decision to initiate chronic opioid therapy is not something that is done lightly and should occur after a thorough review of the situation and with shared decision-making with the patient. It is important to have as complete an understanding of the underlying pain disorder as possible. Sometimes this is difficult to do, and if the reasons for the pain being treated are not clearly identified, you should pause and reconsider initiating chronic opioid therapy. Having a thorough understanding of the pain will also allow you to design a treatment plan that makes best use of non-opioid therapy as well. Non-opioid therapy should be maximized along with chronic opioid therapy in order to achieve the best outcomes in pain relief and function. A thorough history and physical examination pertinent to the problem is imperative in determining the cause for the pain and developing a treatment plan. This also includes reviewing any pertinent medical records of past workup and treatment. Once this has been done, a risk-benefit analysis can help decide how best to proceed. Like any treatment we provide, opioid therapy has risks, and our goal as clinicians should always be to minimize these risks while providing the greatest benefit. A history of obstructive sleep apnea, cardiovascular disease, pulmonary disease, liver disease, and renal disease all can impact the safety profile of opioids and need to be considered before initiating this therapy. For instance, patients with obstructive sleep apnea have a much higher risk of respiratory depression on opioids, which is dose-dependent. Opioid abuse is another risk that must be addressed prior to initiating chronic opioid therapy. That can be done with a number of tools, but a simple one that has good predictive value is the Opioid Risk Tool. This is a simple questionnaire that can help determine the risk of opioid misuse and can help us categorize patients into low risk, medium risk, and high risk categories. This is important information to know and can help guide us in deciding whether or not to initiate opioid therapy and how closely to monitor the patient on chronic opioid therapy. Finally, if the decision is made to proceed with chronic opioid therapy, it is rarely a good treatment plan that opioids alone are used. Opioids should always be just part of the treatment plan that includes a multidisciplinary, multimodal approach. Once the decision has been made to initiate chronic opioid therapy, you need to have an open discussion with the patient about the goals for this therapy. Goals for each patient are very individual and need to be tailored for their specific situation and needs. For instance, some patients with severe cardiopulmonary disease may be limited in their walking ability, no matter how much pain relief they have. so a goal of increasing their walking tolerance by a half a mile per day may be inappropriate. Generally, the goals of any pain treatment, including chronic opioid therapy, are for improvement in pain control and function. Functional improvement is not only measured by physical function, but also emotional and social function as well. What is considered meaningful improvement is not well defined, but overall, a 30% improvement is considered a reasonable measure of success. While verbal pain rating scores are commonly used and widely understood, they only provide a unidimensional way of measuring pain and outcomes. A better tool is one that measures not only pain, but also its impact on function and quality of life. The PEG score does just that. This is a validated assessment that measures average pain, interference with enjoyment of life, and interference with general activity. Utilizing this tool routinely at appointments can give a more accurate picture of the success or failure of the treatment plan. When initiating opioid therapy, a discussion on the risks and benefits is essential. We have discussed previously that while there is benefit of opioids in the management of acute pain, use of opioids in chronic pain is controversial and not well supported in the available literature. There are common side effects of opioids, including nausea, constipation, CNS depression, tolerance, and physical dependence. Tolerance refers to the adaptation of opioid receptors to opioids, requiring higher doses to be used to produce an effect. This limits the effectiveness of chronic opioid therapy and is sometimes a reason for failure of this treatment. The development of tolerance is very individual, but tends to be more pronounced in younger patients, those less than 45 years of age, and less pronounced in older patients, those greater than 65 years of age. Physical dependence occurs when someone has been exposed to high enough opioid doses for a prolonged period of time, such that withdrawal effects can occur if the medication is stopped abruptly. Doses above 20 milligrams of morphine equivalents per day can be associated with dependence. This is quite different from addiction, which signifies a compulsive behavior that continues despite harmful effects of that behavior. Finally, a discussion with the patient about the risks of overdose is imperative so that the patient is fully informed of the risks. It is important to point out that overdoses can occur even when the patient is taking medication as prescribed, especially if high doses are used, and is not necessarily just a consequence of someone overtaking their medications. Remind the patient that the goals of chronic opioid therapy is primarily to increase function and secondarily to decrease pain. These often go hand in hand, but do not always. There are many people that gain significant improvements in function with less significant improvements in pain rating. When initiating opioid therapy, always start with short-acting opioids. Short-acting opioids are easier to titrate and are metabolized quicker if an adverse effect occurs. Some patients on chronic opioid therapy do very well in the long term utilizing short-acting opioids. If a patient is on a stable dose of short-acting opioids, it may be beneficial to change them to a long-acting opioid to avoid the more frequent dosing interval of short-acting opioids. This can be especially important at night when sleep patterns can last longer than a short-acting medication and the patient awakens in severe pain. In general, use of a long-acting opioid with short-acting opioids for breakthrough pain is not advisable in chronic non-terminal pain. Methadone and transdermal fentanyl can be effective analgesics, but generally should not be used unless you are familiar with the dosing and elimination properties of the drug. A referral to a pain specialist is prudent if these medications are being considered. A guiding principle for prescribing opioids, as with any pharmacologic, is to use the lowest effective dose possible. The risks of opioids increase with increasing dose, so keeping the dose as low as practical is helping to protect our patients. A common misconception about opioids in both patients and healthcare providers is that opioids should give complete relief. This is false, but if the expectation in a chronic pain patient is that opioids are going to completely or nearly so relieve their pain, then anything short of that is met with frustration by the patient and the healthcare provider. The natural consequence of this expectation is to increase the dose until near perfect pain control is achieved, which we know is not possible. With acute, self-limited pain, opioids often do lead to a dramatic decrease in pain. However, Studies have shown that this curve is shifted when opioids are used to treat chronic pain. When opioids are used for chronic, non-terminal pain, pain reduction on the order of 30 to 40% is what can be expected. Essentially, these medications take the edge off. Pursuing more dramatic relief without evidence of benefit will leave the patient and the healthcare provider frustrated, and doses may be increased to potentially dangerous levels in search of better pain control, the opioid treadmill, so to speak. Close monitoring is a mainstay of chronic opioid treatment so that you can identify when a plateau of pain control has been reached, and increasing medication beyond this level just increases risk without benefit. Most patients do well with opioid doses at less than 50 milligrams of morphine equivalents per day, and going beyond that should not be done without serious consideration. It is always a good idea to obtain a pain management specialist consultation if it becomes apparent that higher doses may be necessary. As a general rule, if I have not seen a trend towards notable improvement in pain and function by 40 milligrams of morphine equivalents per day, I consider the therapy a failure and reassess. A change to a different medication or a taper off opioids may be necessary. One of the ways of managing risk for chronic opioid therapy is to address acute pain and the use of opioids. This is not the focus of this talk, but it is an important part of managing long-term risk. We do know that some people are at risk of opioid dependence and developing opioid use disorder when opioids are used for as little as 3 days. Opioids can be very effective for acute pain and should not be withheld from a patient in need of pain control. However, for most causes of acute pain, including surgery, opioids are rarely necessary beyond 7 days, and for more minor procedures, 3 days is often enough. It used to be common for healthcare providers to give larger than necessary prescriptions to avoid multiple phone calls and to avoid having to write another controlled prescription which couldn't be called into the pharmacy. Now, with e-prescribing and EHRs, prescriptions can be sent electronically, making it easier to address refills if necessary. Large prescription quantities are no longer necessary to cover the contingencies. This helps to keep extra medications out of medication cabinets and less available for diversion. Relatively frequent follow-up is necessary when prescribing chronic opioid therapy to monitor the therapy and ensure that goals are being met. When opioid therapy is initiated, follow-up should be more frequent. Intervals of 1 to 4 weeks are common during this phase. The frequency of follow-up visits after that can be decreased if the patient is stable and risk of opioid misuse is low. In our clinic, patients on stable doses less than 50 milligrams of morphine equivalents per day and at low risk as determined by their ORT score may only be seen once every 3 months. This frequency is shortened if therapy is being adjusted. Patients who are on high doses of opioids, defined as greater than 50 milligrams of morphine equivalents per day, or very high dose opioids, defined as greater than 90 milligrams of morphine equivalents per day, or who are at higher risk of medication misuse as determined by ORT, are seen more frequently. Telehealth may be used for some visits, but I think a face-to-face visit is necessary at least every 3 months. There are many reasons why it may be appropriate to taper a patient partially off or completely off their pain medication. We have discussed treatment failure as a reason to taper off opioids and reassess for another therapy. Patients themselves may request to taper off the medications. If someone is demonstrating evidence of a substance use disorder, that is a reason to taper off opioids. A serious adverse event like an overdose should prompt a review and strong consideration for tapering. Likewise, if a patient is showing signs of a relative overdose by demonstrating increased confusion, sedation, and even slurred speech, tapering off opioids should be done before they end up having a serious adverse event. I am often asked how to taper someone off opioids. If this is a situation that does not require a rapid taper, a gentle taper of 10% per week or per month is reasonable. This can be the patients who request to be tapered off their medications or legacy patients who are on high doses of opioids with minimal benefit. A gentle taper can help minimize the effects of withdrawal and is generally well tolerated. Once it has been decided to taper, I would avoid reversing the taper. The taper schedule may be held or adjusted to be more gradual if necessary. In patients with the presence of dangerous illicit substances on urine drug screens, stopping prescribed opioids and CNS depressants, and a referral for substance abuse treatment is appropriate. Managing risk is crucial to help minimize the risk of serious adverse events. Obstructive sleep apnea is a risk factor for respiratory depression in the presence of opioids. This is especially true if there are other comorbidities like congestive heart failure, obesity, and renal disease. Avoiding opioids during pregnancy is important to avoid harm to the mother and child. However, in circumstances where chronic opioid therapy is necessary for the mother, it is best if the mother can be monitored and delivered at a facility that is capable of treating neonatal abstinence syndrome. If possible, opioids can be tapered at the end of pregnancy to help avoid neonatal abstinence syndrome. For pregnant women who suffer from opioid use disorder, referral for treatment with buprenorphine or methadone has been associated with better outcomes and should be initiated. Patients with renal and/or hepatic insufficiency need close monitoring. They are more prone to difficulties with metabolizing and eliminating opioids and have a narrower therapeutic window with these medications, placing them at higher risk for serious adverse events. Older patients may be more at risk for chronic non-terminal pain and at the same time more susceptible for accumulation of opioids due to poor kidney and liver function. A thorough medication review is necessary to check for potential interactions. Anxiety disorder and depression are risk factors for medication misuse, and these conditions frequently interfere with successful pain control. Patients with severe anxiety may be on a benzodiazepine, which can interact with an opioid and increase the risk of respiratory depression and even death. Patients with significant depression need this managed with treatment other than opioids. Poorly treated depression is associated with poor outcomes to pain treatment. TCAs and SNRIs can be very beneficial in these patients, treating both conditions at the same time. Patients with an active substance use disorder are poor candidates for chronic opioid therapy and should be referred for treatment of their substance use disorder instead. Patients with a history of substance use disorder should not be denied chronic opioid therapy if it is clinically indicated, but this needs to be considered carefully and openly with the patient. They should be made aware of the risks of chronic opioid therapy in them, including a relapse to substance use disorder behaviors. Alcohol is frequently added as a pain management strategy by patients, and this should be screened for and counseled against. Any CNS depressant, including alcohol, increases the risk of adverse events with opioids and should be avoided. We have some very important tools at our disposal to help us manage the risks in our patients. Patient drug monitoring program data should be reviewed at every visit, or at least before every refill of opioid medication. This report contains the latest prescriptions filled, the date written, the date filled, the prescribing provider, and the number of providers and pharmacies the patient has used, typically for the last 2 years. This helps to deter doctor shopping and can help to eliminate unnecessary prescriptions. These reports can often alert a provider to a medication the patient is taking that was not known to the provider and may have potential interactions with the prescribed opioid. These reports are readily obtained and are integrated with most EHR systems now to allow for easy retrieval and review. The State Medical Board of Idaho recommends that the PDMP is checked before initiating chronic opioid therapy and with each refill. Urine drug screens are another important tool for monitoring chronic opioid therapy. This allows the healthcare provider to confirm that the prescribed medications are being used and that other substances, including illicit substances, are not being used. Urine drug screens should be obtained before initiating chronic opioid therapy, and then randomly thereafter. We base the frequency of our urine drug screens on the risk profile of the patient. A patient with low risk of opioid misuse, as determined by the opioid risk tool, will get a urine drug screen 1 to 2 times per year. Someone who is in the medium risk category will get 2 to 4 urine drug screens per year, while a patient in the high risk category may get 4 to 6 or more per year. Opioids and benzodiazepines both depress the CNS and can reduce the respiratory drive. Concurrent use compounds this risk and increases the risk for potentially fatal overdose. The combination of methadone and benzodiazepines has been shown to be especially dangerous. Co-prescribing these medications should be avoided. If patients are on both classes of these medications, A discussion with the patient about these risks is necessary, and preferably one of these drug classes should be tapered off. Tapering benzodiazepines should be done very gradually, as a rapid taper can lead to significant adverse consequences, including rebound anxiety, hallucinations, seizures, delirium tremens, and even death. Benzodiazepines can be gradually tapered by 25% every 2 weeks. If the patient needs to stay on benzodiazepines for mental health reasons, a conversation with the mental health provider to review the risks of the concurrent therapy is necessary to help decide how best to manage the patient's ongoing pain and mental health issues. Before we come to a close, I think it is important to spend some time on opioid use disorder. This is simply defined as a problematic pattern of opioid use leading to clinically significant impairment or distress. DSM-5 has multiple criteria for the diagnosis of opioid use disorder, and I have taken the time to list them here because I think it is important that we are familiar with them. These criteria include opioids taken in larger amounts or for longer periods than intended, persistent desire or unsuccessful efforts to cut down on use, a great deal of time spent obtaining, using, or recovering from the opioid, craving, continued use in spite of interpersonal problems caused by opioids, reduced social, occupational, or recreational activities due to use despite being physically hazardous, continued use with persistent physical or psychological problems due to use. Two additional criteria, opioid tolerance and opioid withdrawal, are also included in the DSM-5 for opioid use disorder. However, it is important to remember that in patients on chronic opioid therapy, taking the medications as prescribed and not demonstrating the other opioid use disorder criteria, tolerance and withdrawal are considered physical manifestations of being on chronic opioid therapy and are not signs of opioid use disorder. If you suspect your patient has opioid use disorder, have an open and honest discussion with them. Review the criteria for opioid use disorder and explain to them why you think they have an opioid use disorder problem. Be non-judgmental and approach this like any other disease that needs treatment. This approach may allow the patient to open up about their problems and may help to facilitate treatment. If you have a waiver from SAMHSA, offer treatment with buprenorphine or naltrexone. Alternatively, offer a referral to a substance abuse specialist or an opioid use disorder treatment clinic if there is no one in your practice area. A patient with an opioid use disorder should not be discharged from your practice based on that alone. Reassure them that you are willing to continue treatment of their pain using non-opioid therapies. Patients who feel they have the continued support of their healthcare provider are going to be more likely to seek the care they need. The recommendations for managing chronic opioid therapy that I have discussed are based on CDC guidelines and my 25 years of experience in the field of pain management. The practices discussed in this talk are important for all healthcare providers, whether they personally manage chronic opioid therapy or refer to specialists for this. Management of patients on chronic opioid therapy can be challenging, but for some patients it can be life-altering in a positive way. Our knowledge of best practices is constantly changing, so it is important to be open to new ideas and treatment strategies as things develop. Thank you for participating in this educational activity.
A patient's understanding of their prescriptions is a process in which you, the provider, play a crucial role. It starts by asking patients questions on the phone when they make an appointment and ends when they are handed their prescriptions by a pharmacist. Your time to shine is right in the middle. As a busy provider, we know that asking you to do one more thing during office visits is a lot to ask. So let's have a simple conversation about what, when, and how to ensure your office is checking all the boxes. Prescription opioid medications have contributed to intentional and unintentional overdoses. In addition to our adult population presenting in the emergency department for overdoses, every year, young children are brought to the emergency department for accidental overdose, often from finding pills. What can your practice do to ensure patient safety? These 5 quick steps can make sure you've checked off all the boxes. Screen. Provide follow-up screening. Question yourself. Co-prescribe and counsel on naloxone. And educate on medication storage and disposal. Let's see what this might look like in action.
Howdy, Wellness Clinic. How may I help you today?
Hello, this is Patty Smith. I'm calling to schedule my annual wellness visit.
Excellent. Thanks for calling, Patty. So I look up my schedule. It looks like we can get you in next week. Is there anything specific you'd like to discuss with your provider?
Not really, but I have been having a lot more pain recently. But who doesn't, right?
Right. Well, if you'd like, I can schedule you for a longer appointment time. That way, you'll have the opportunity to discuss with your doctor these issues. Would you like that?
Yes, that'd be great.
Excellent. Also, would you mind bringing in all the medications you're currently taking so we can talk about them together?
I can do that.
Excellent. See you next week.
Yeah, thank
Ciao.
you.
Hey, great to see you, Patty.
Hello.
Thanks for coming in for your appointment. Would you do us a big favor and fill that paperwork out for us, and we'll get you back to see the doctor as quick as we can?
Yes, I'll do that.
Excellent. Thanks.
Check your patient's risk of substance use disorder. This can be done through intake paperwork, a medical assistant, or yourself, depending on where it fits best in your office workflow. One key question can make all the difference. For example, the SBIRT model asks, how many times in the past year have you used an illegal drug or used a prescription medication for non-medical reasons?
Okay, Patty, I noticed that you answered yes to this particular question. If it's okay, I'd like to ask you some additional questions as follow-up. Now, these are sensitive questions, but if you answer them honestly, it'll allow us to provide you the very best of care. Okay?
Okay.
All right, great. So, this particular question right there.
Yes.
That one?
No.
That one?
Yes.
If the patient answers yes to using illegal drugs or prescription medication for non-medical reasons, follow up with more in-depth screening. For example, the CAGE aid, DAS-10, PHQ-9, or a combination of all. As a team, decide which tools are the best fit in assessing a patient's risk for substance use disorder.
Patty, thank you so much for answering these questions. Do you have any comments or any reservations about anything that you answered here?
No.
Excellent, excellent.
I
And
did bring all my medication, though.
awesome. Thank you for bringing those in. Let's go ahead and review these. With this one right here, can you tell me a little bit about how you take this?
You know, I usually take one when I get up and one when I go to bed at night.
Okay.
I know it says 3 times a day.
Okay, great. Thank you so much. All righty. I'll let you have those back and I'll call the doctor. Thanks.
Thank you.
Hey, hi, doctor. How you doing?
Good. How are you today?
Great. Hey, Patty's ready to see you. But before you go in, I wanted to let you know she did check yes on the SUD screening question.
I see that.
Because she lives in a rural area. She has both an opioid and a benzodiazepine prescription according to her PMP. And then during the follow-up screening, she indicated that she regularly drinks alcohol. So I think she might be a great candidate for a naloxone prescription.
Oh, excellent. Thank you for sharing that. I'll keep that in mind.
You're welcome. Take care.
Thanks. Patty, everything is looking good. I'd like to still continue reducing your Ambien dose, though, like we've been working on for the last couple months, just where you're still taking that opioid pain medication regularly.
Have I prescribed a new controlled substance? Have I changed a dosage or the frequency of taking a medication? If yes to either question, Consider co-prescribing naloxone and discussing medication safety. Co-prescribe and counsel on naloxone for opioid prescriptions. Consider co-prescribing naloxone as an option for your patient, especially if the patient had previous emergency medical care involving opioid intoxication or overdose, has a suspected history of substance use disorder or non-medical opioid use, has a prescription for methadone or buprenorphine for the treatment of substance use disorder, has been prescribed a high dosage of an opioid, greater than 50 morphine milligram equivalents a day, has barriers to accessing emergency medical services such as a rural home address, receives an opioid prescription plus a concurrent benzodiazepine, use of alcohol and tobacco, or comorbidities of pulmonary disease, cardiovascular disease, large organ failure, or mental health disorders.
Additionally, I'd like to prescribe you a medication called naloxone. Have you heard of that?
I haven't, but news takes a while to get to my town.
That's a good point, Patty. Even if you're taking the medication as prescribed, which you're doing a great job at, we want you and your loved ones to know what to do just in case there are any adverse side effects from your opioid medications that you're currently taking.
How often do I take it?
That's a great question.
Proceed to counsel on how to use naloxone. Inform a patient that naloxone is administered by another person. Ask to invite a loved one into the room to learn how to use naloxone. If able, the person administering should be calling 911 immediately. Encourage further education when picking up the prescription from the pharmacy and making sure the additional party is present.
Naloxone will give you and me a little more peace of mind and help us continue to manage your pain while still taking your regular medications as prescribed.
That's good to know. I'll make sure to take my husband or daughter with me when I pick up my prescription.
Oh, excellent. Speaking of that, how do you keep your medications stored at home?
I usually just put them all out on my kitchen counter so I can see them.
You know, it's always nice to have that visual cue, but we want to keep those grandkids that you love so much safe and those medications secure. Would you like a free medication lockbox today?
Yes, that would be great.
The box will serve as a visual reminder to take them on time, and that way everyone stays safe.
Take the opportunity to provide information on safely storing and disposing of medications. These easy steps can help keep a patient, their family, and our community safe from drug misuse and accidental overdose. When talking with your patients, share why it can be risky to keep unused medications around. Children or pets can unknowingly get into them, since pills might look like candy. Also, medicines could be stolen by a visitor without the patient knowing. A lockbox is suggested for storing controlled substances. Expired or leftover medications should be disposed of quickly, either at a law enforcement building, a biannual drug take-back day, or in a medication disposal pouch. Reassure patients that hanging on to meds is more risky than rewarding, and as their provider, you'll always be available if they have future pain or other conditions that need to be treated.
Hey, Patty, great to see you today.
It was good to be here.
Thank you so much for coming in.
Thank you.
Let's just review what we talked about today. You came in for your annual wellness check as well as for pain management. Now, do you need a medication lockbox?
You know, I do. The doctor told me about those.
Oh, awesome. So there you go. In addition, we're going to go ahead and give you a medication disposal pouch. This is great for disposing of unused medications or medications that are out of date.
You know, this looks really easy to use.
Oh, they are. They're great. Well, thanks for coming in. And remember, if you have any questions about anything that happened today or the medications, be sure and give us a call. And the pharmacist will also be able to answer any questions. And don't forget to take somebody with you when you go.
Okay, thank you so much.
Have a great one. We'll see you. Be safe.
You can find these resources and more, including educational information cards, medication disposal pouches, and medication lockboxes, free and available at all 5 Panhandle Health District locations in Bonners Ferry, Hayden, Kellogg, Sandpoint, and St. Mary's. Medication disposal pouches provide a safe and convenient way for people to dispose of their medications at home, and medication lockboxes provide safe storage. Disposal pouches and lockboxes are provided by the Idaho Region 1 Behavioral Health Board, Panhandle Health District, and Idaho Office of Drug Policy through the Partnership for Success grant funding. Contact your local Panhandle Health location to request supplies to help you provide these resources to your patients. We know that fitting one more thing into a visit is a challenge. Structuring patient visits enables you to personalize their individual needs using these 5 checks: screen, provide follow-up screening, question yourself, co-prescribe and counsel on naloxone, and educate on medication storage and disposal. Thanks for making North Idaho a healthier community.